Learning objective number 38, acne. Understand the presentation, evaluation, and management of acne. Acne vulgaris is a chronic inflammatory disorder of the pilosebaceous units, characterized by comedones, which are non-inflammatory lesions, and by inflammatory papules, pustules, and nodules on sebum-rich areas, such as the face, chest, and back. Acne is the most common skin condition in adolescents and typically presents at about 11 to 14 years of age. However, it can occur from infancy through adulthood. 4 interrelated processes drive the development of acne: follicular hyperkeratinization, excess sebum production, Cutibacterium acnes proliferation, and inflammation. Risk factors include family history, a high glycemic diet and skim milk, oily hair or oily skin products that may lead to occlusion, and in rare cases, early adrenarche, polycystic ovary syndrome, and following the use of certain medications, such as corticosteroids, phenytoin, anabolic androgenic steroids, and isoniazid. Acne may present with comedones, either primarily open comedones, also known as blackheads, or closed comedones, also known as whiteheads, associated with minimal inflammation. Acne may also present as inflammatory, characterized by predominantly erythematous papules and pustules, often mixed with comedones. Nodulocystic acne is characterized by numerous, large, often greater than 5 millimeters, deep, painful nodules and cysts. Nodulocystic acne is associated with a high risk for permanent scarring. There are also distribution and age-related patterns of acne. For example, again, acne vulgaris typically presents at 11 to 14 years of age, most commonly on the face, but also potentially involving the neck, chest, shoulders, and even the back. Neonatal acne commonly presents with pustulosis with papules and pustules, but without comedones. Neonatal acne is typically benign, and parents can be reassured and advised to use gentle cleansing. Infantile acne, typically presenting between 6 weeks and 12 months of age, is true acne associated with both comedones and inflammatory lesions. Treatment with topical retinoids and benzoyl peroxide is typically recommended. Mid-childhood acne, presenting between the ages of 1 and 6 years of age, is rare and should be considered as a red flag for hyperandrogenism. Finally, pre-adolescent acne, presenting between the ages of 7 and 11 years, is usually mild, but is increasingly common as an early sign of adrenarche. Manage pre-adolescent acne the same as adolescent acne. Acne in unusual age groups, such as infancy and during mid-childhood, warrants evaluation for an underlying endocrine abnormality. The diagnosis of acne is clinically based on characteristic lesion types such as comedones, papules, pustules, and nodules in a typical distribution, and typically no laboratory testing is required for routine acne. Be sure to document the presence of atrophic scars, hypertrophic scars, keloids, and post-inflammatory hyperpigmentation. Scarring indicates the need for more aggressive treatment to prevent further damage. Also, keep in mind that acne significantly affects self-esteem and may oftentimes cause anxiety, depression, social withdrawal, and bullying. Effective treatment improves mood and quality of life. And be sure to screen for depression and for suicidal ideation, especially in severe cases or when starting oral isotretinoin. If oral isotretinoin is planned, be sure to obtain baseline liver enzymes and fasting lipid levels, and also check pregnancy testing monthly for those who can potentially become pregnant. In females with severe acne and or signs of hyperandrogenism, be sure to evaluate further for the potential of polycystic ovary syndrome. As previously mentioned, mid-childhood acne, which occurs in children between the ages of 1 and 6 years, is very uncommon and is a red flag for hyperandrogenism, requiring workup for such disorders as precocious adrenarche and congenital adrenal hyperplasia. The differential diagnosis of acne includes drug-induced acne, characterized by monomorphic papules and pustules in the absence of comedones, folliculitis, characterized by uniform pustules with surrounding, oftentimes pruritic erythema, but no associated comedones, rosacea, which is rare in children and characterized by facial erythema that is oftentimes triggered by spicy food or temperature changes. Rosacea is associated with papules and pustules, but not with comedones. Included also in the differential diagnosis is perioral dermatitis, characterized by erythematous papules and pustules around the mouth and nose. No comedones are associated. Perioral dermatitis is oftentimes exacerbated by topical corticosteroids. Finally, hidradenitis suppurativa is characterized by recurrent, painful nodules, abscesses, and sinus tracts in intertriginous areas. Also, be sure to urgently refer patients with acne fulminans, which is characterized by the abrupt eruption of extremely painful nodules or ulcers associated with both fever and arthralgia. Regarding management of acne, begin with topical therapy and basic skincare. Discourage picking and encourage appropriate use of sunscreen. Treat mild comedonal acne with nightly topical retinoids, which are the cornerstone of therapy for all acne severities and as maintenance therapy following clearance of more significant acne. Treat mild to moderate inflammatory acne with both benzoyl peroxide as well as a retinoid. If treating with topical clindamycin or erythromycin, be sure to pair with benzoyl peroxide and limit treatment to no more than 12 weeks. Mild to moderate inflammatory acne typically improves within 6 to 8 weeks. Escalate therapy for more extensive or deeper disease. Treat moderate to severe inflammatory or truncal acne with oral doxycycline for up to 3 to 4 months, always with a topical retinoid and benzoyl peroxide. Be sure to avoid antibiotic monotherapy. Severe refractory nodulocystic acne should be considered an indication for oral isotretinoin. Be sure to refer such patients to a dermatologist promptly to avoid the potential for scarring and or marked psychosocial distress. Anticipate mucocutaneous dryness and photosensitivity when using oral isotretinoin, and never combine oral isotretinoin with doxycycline. In menarchal females with menstrual flares, oftentimes combined oral contraceptive pills or spironolactone will improve acne. Finally, for those who are pregnant, Treatment with azelaic acid and benzoyl peroxide is recommended. Be sure to avoid all retinoids, tetracyclines, and isotretinoin.